goals at this time. So that's my brief little blip on time management, because I do think it's false economy, although, medical school is changing a lot, but, not to cram for these tests and pathology, et cetera, et cetera. Sepsis syndrome, a differential diagnosis of the flu-like illness. To give you a 42-year-old woman with, this case ended up in court, chills, nausea, and diarrhea, temperature of 102, blood pressure 90/50, pulse 120, normal exam, white count 6,000, given a diagnosis of gastroenteritis, dehydration, IV fluids, and sent home. What's wrong with that picture? Excuse me?
Somebody looked to see what was the cause of her gastroenteritis.
Yeah, she's sick. She's very sick, and she's given a presumptive diagnosis that might be wrong. And as it turns out, she died of bacteremic pneumococcal pneumonia. And the body, as you know, as you're learning in pathology, can only react to injury in a few ways. And one way that it reacts to stress is you get sick in you feel sick in your gut. But this person is sick, given IV fluids and sent home. The most important aspects of medicine 3 are diagnosis, diagnosis, diagnosis. A normal white count probably threw them off. Nobody looked at the cells, and one of my mottos is to let the leukocytes talk to you. Actually look at the peripheral blood smear and see whether you've got bands and holes in the polys and toxic granules and all of that. Sepsis was called by a 19th century Philadelphia surgeon a rude unhinging of the machinery of life. It reminds me of this shipwreck painted here by Turner. And as we'll see, just about everything in the body goes haywire in sepsis. Traditional definitions for what we're going to talk about are bacteremia, meaning a positive blood culture, the presence of organisms, usually bacteria, can have fungi or other organisms in the blood. Sepsis, the harmful consequences of microbes and their toxins in blood or tissues. Septicemia, meaning bacteremia with clinical manifestations, and then septic shock caused by sepsis, often with a positive blood culture. And this makes this distinction that if we look at the world of people with positive blood cultures and the world of sick people who have signs consistent with sepsis, these people, what's wrong with these folks here? What does that tell you about their blood cultures? They're false positive, or they might be transient bacteremia. They're inconsequential, positive blood culture. But in general, in clinical medicine, we get lots of blood cultures because blood cultures are worth their weight in gold when they're positive for telling you something. And septicemia meant bloodstream infection. That was people with signs of illness who also had positive blood cultures. These definitions have been revised, and it's really, I think, mainly a semantic distinction, but they've been revised as follows, and this is not stuff that's going to be on my exam and not stuff to really harp on, because I think these are arbitrary definitions, but it will come up on the wards. The systemic inflammatory response syndrome, and that's a term coined to take into the idea that other things besides infection can cause sepsis. I just came from a hospital where I was asked to see somebody who had a high white blood count, for example, and she had lots of things that might explain being sick besides infection. Sepsis would mean inflammation, systemic inflammatory response caused by sepsis, and then severe sepsis, in which there's evidence that one or more organs is in trouble, kidney failure, decreased urine output, clouding of the consciousness, abnormalities of blood coagulation, hypoxemia, and then septic shock defined as hypotension or shock that does not respond to simple fluid replacement. So The systemic inflammatory response syndrome, or SIRS, a term that you'll encounter, basically defined by abnormal vital signs, a high temperature, a high respiratory rate, and either a high white count or a low white count with bandemia, immature forms. The respiratory rate is a commonly overlooked physical finding that's not taken accurately a lot of times. You'll see people just write down 12 or 16 or 20. And my preferred way to do it is to put your hand on the belly and look at your watch. If tachypnea is an important finding, what would tachypnea, an increased respiratory rate, indicate in sepsis? Sure, it's an attempt to respiratory compensation for metabolic acidosis. Very, very good. And it is important that some people will have a normal or low white count with a bandemia, and oftentimes these people are very, very sick. Sepsis would be an inflammatory response plus documented infection. Severe sepsis, I've already given you that definition, organ dysfunction such as lactic acidosis, oliguria, altered mental status, or hypotension. Septic shock, hypotension despite fluid resuscitation. And here's the key distinction. The hallmark of septic shock is low systemic vascular resistance. You look simplistically at three different types of shock. In hemorrhagic shock, by definition, the blood pressure, the blood volume is low. In cardiogenic shock, failure of the heart as a pump, the blood volume is normal. And in septic shock, the key word is sequestered. The blood volume is normal, but it's sequestered peripherally in inappropriate places for perfusion of vital organs. So in septic shock, the blood volume is sequestered, and low systemic vascular resistance would be a hallmark. And a unifying idea, and these ideas continue to evolve, and what's happening in the basis for this systemic inflammatory response syndrome is endothelial damage that causes a generalized inflammatory response, leading to then this cascade: sepsis syndrome, septic shock. And the patients who are in today's intensive care units with multiple lines on ventilators, et cetera, frequently have multiple organs that have been knocked out, and the mortality rate goes up exponentially as one after another organ begins to fail. This rather elaborate slide simply, it's almost an incomprehensible slide, isn't it? Somebody drew. Systemic inflammatory response syndrome, or SIRS. We note that pancreatitis, burns, trauma, and other insults to the body, like sepsis, can cause inflammation. So as I pronounced this morning, we treat infections, not high white. We treat patients, not high white counts. Sepsis, the world of things wrong with you as a result of infection. And then in this subset, we have positive blood cultures for bacteria, fungi, parasitemia. In a review article that I wrote some years ago, I suggested the term microbemia to separate this, just microbes in the blood. And the editors threw that out. They didn't like it, which is a shame because I thought it was a perfectly good word. But probably too many words out there anyway, aren't there? In severe sepsis, and we're going to talk mainly about positive blood cultures in this hour. Blood cultures are positive in about 20 to 40% of cases. So there's a low sensitivity, but again, they're worth their weight in gold if they're not contaminants. In septic shock, blood cultures are positive in about 40 to 70% of cases. One implication that you see from this slide would be there's going to be a lot of empiric antibiotic therapy going on, right? Which drives drug resistance and other things. So let's talk a little bit about blood cultures, which for a long time was my major sort of research hobby. There are a number of ways that you can look at positive blood cultures. It can be, one is true positive versus false positive. It could be contamination or pseudobacteremia, and some organisms, and this has been evaluated by correlating blood culture results with meticulous review of charts by several observers, and some organisms are usually contaminants. Coagulase negative staph, it said, are contaminants about 95% of the time. With other organisms, such as the pneumococcus and gram-negative rods, are true pathogens about 100% of the time. Always true pathogens. Staph aureus, interestingly enough, is a true pathogen only about 75% of the time. And that would be the case because staph could be part of the blank flora on a transient basis. Skin flora. Skin flora. You got it in your nose. A study in the London subway suggested that at a given hour, 30% of the people stick their fingers in their noses. So, you're going to have bacteria transiently on your skin. Transient versus intermittent versus continuous makes the point that, say we get blood cultures throughout the day, an occasional blood culture might be positive in all of us. We might have bacteria in our blood which are fairly promptly cleared by the reticular endothelial system. So transient bacteremia is usually inconsequential, but can, to amplify on the previous lectures, play a role if you have what going on? What was that fancy Latin phrase I threw out in an earlier lecture? You're looking at him, he doesn't know anything. A locus, what was the rest of it? You clueless? A locus minoris resistentiae, right? Place of least resistance. It was at the tip of your tongue all along, wasn't it? A locus minoris resistentiae. And so this becomes very important. This is, for example, having an abnormal heart valve, some aortic regurgitation, for example. If you have a transient bacteremia going on, then bacteria will cover this in the remainder of the hour, will settle out there, and all of a sudden you got endocarditis, right? So this is the basis for giving prophylactic antibiotics in people with heart murmurs who have certain heart murmurs before dental extraction, for example, right? So transient bacteremia has a role in pathogenesis. Intermittent bacteremia, some blood cultures are positive, but not others, but not all of them, is characteristic of most infections that give the bacterial infections, et cetera, that give rise to positive blood cultures. And sustained or continuous bacteremia, that means all of the blood cultures are positive, is characteristic of intravascular infections, most famously endocarditis, but also infected AV fistula or dialysis grafts, septic thrombophlebitis from IV catheters, and certain other examples. Sometimes you just have a few bacteria in the blood. Other times you have massive bacteria in their blood. Usually you have one organism. Sometimes you can have several, especially if you had, say, a complicated intra-abdominal infection. Primary versus secondary means whether or not you have a recognized source, secondary bacteremia, as opposed to no obvious source. If there's no obvious source, you should think endocarditis, or you should think a line infection. Clues to contamination. Certain organisms are usually contaminants, such as coagulase-negative staph. And then the patterns of the number of cultures, you'll get this from the wards in spades. It doesn't fit the clinical picture. It doesn't fit the clinical picture. Transient, intermittent, and sustained or continuous. Transient again, manipulation of a flora-containing body surface. And there's a large literature on the frequency of positive blood cultures after brushing your teeth vigorously, doing an endoscopy, having a trach done, having urologic surgery done, things, debriding an ulcer vigorously. And we mentioned popping zits earlier. I'm not sure that's been studied. Maybe y'all could volunteer for that. But I don't see many zits out there, so we probably couldn't. But there's a large literature on the frequency of transient bacteremia, again important for pathogenesis. Intermittent and sustained or continuous endocarditis, endarteritis, septic thrombophlebitis, infected AV fistula. Any questions so far? I'm going to skip that. Sepsis is clinically a very important problem. Contributes to about 3 times as many deaths as highway accidents. Overall incidence is said to be very substantial. Most cases occur in patients hospitalized for some other illness. Others, of course, occur as community-acquired infections, so it's very common, sepsis. And in the hospital, this has become, over the past half a century, a very major issue because of the things that we do to people. Gram-negative bacilli were the story up until about 1980, because it became recognized that as penicillin and other antibiotics cured gram-positive infections, we began to see gram-negative infections in people who were very, very sick. In recent years, gram-positive cocci have become the storyline, particularly drug-resistant ones, and this is, I think, in part due to our rampant use of lines in anybody who comes in and gets sick. Whereas if you got sick in around 1830, if you rolled in for any reason, I would get a lancet out of my pocket and bleed you. Now, if you roll in for any reason, I'm going to put in a big line, right? How many of you worked in hospitals? Do you agree with what I just said? Sure. You get a big line. Whatever it is, you got to have a line, right? A lot of what we do, take a skeptical attitude with you. A lot of what we do has to do with the style of medical practice, the climate of it. Fungi are also, when I studied all positive blood cultures in Columbia for 5 years between 1977 and 1981, and didn't even include fungi because they were not even or yeast. They weren't even a blip on the radar screen. But now yeasts are very important. Host factors. Lots of studies have shown that the likelihood of dying from sepsis is directly related to the severity of underlying disease. Rapidly fatal disease, meaning if I just look at you and say you're probably not going to walk out of this hospital. Very high mortality, ultimately fatal, something like that you would die from in 5 years untreated, renal failure, severe heart failure, cancer in any form, versus non-fatal. Most of you, if you had a bacteremic illness, would survive. The mortality would be very, very low. Older people have a higher mortality. My data indicate that the mortality rate begins to rise about in the 5th decade of life, after which you're no longer very important to the gene pool, right? We're kind of made to self-destruct. Mortality is greater in people who have subnormal temperatures than in those with fever, which is important because usually fever is the thing that attracts our attention. Now, against this background data, we're going to contrast gram-positive sepsis and gram-negative sepsis. For quite a while, there was great interest in gram-negative sepsis. Notice that an interest particularly on endotoxin, lipid A moiety of endotoxin, and this contrasts a gram-negative rod with its complicated layer of lipopolysaccharides and lipoproteins here on the outside, whereas gram-positive cocci tend to have a simpler, tend to have teichoic acid here. So differences were suggested. And it was suggested that the hallmark of gram-negative sepsis was that endotoxin, as we'll see, activated Hageman factor, factor 12 in the peripheral blood, which caused 4 bad things to happen, 4 sequences of plasma protein cascades. 1, it activated the kinin system, generating bradykinin, causing vasodilatation early on. 2, it activated the and obviously the intrinsic coagulation pathway, causing disseminated intravascular coagulation. 3, simultaneously, it activated the plasminogen sequence which would dissolve the clots as they formed, and therefore you had what was called a consumptive coagulopathy, where you used up your coagulation system and you began to bleed all over the place. And 4thly, it activated the complement system. However, and I redrew this slide from data. When you look at people with established shock, there's no hemodynamic difference between gram-positive and gram-negative septicemia. So the gram-positive bacteria can do the same thing, although it's a little bit later. The point of this slide is if you look at cardiogenic shock and septic shock, notice that with cardiogenic shock, by definition, the cardiac output is low, the peripheral resistance is variable. It's the opposite with septic shock. In septic shock, the peripheral resistance is low, but the cardiac output is variable. And indeed, there's a lot of information suggesting that the ability to survive septic shock is in part dependent on the ability of the heart to adjust. So, a unifying idea now, and this gets more and more complicated with each passing year, and I'm sure you've had a lot of this, that endotoxin and other molecules as possessed by gram-positive organisms does a whole bunch of things. It activates Hageman factor, causing these things to happen. It activates endothelial cells, the system of macrophages, causing the production of cytokines, activates neutrophils, and also activates the complement system, and all this leads to this systemic inflammatory response. So that's sort of an overview. And again, it gets more and more complicated. If you had the role of nitric oxide in your earlier lectures, you've had all that stuff, and this slide will be, you can pull it up, I guess, on your computer and kind of look at it, and et cetera, and you probably understand it a lot better than I do. But you notice the peptidoglycan, which is in gram-positive bacilli, binding of lipopolysaccharide in gram-negative bacilli, and here you have lots of cytokines being released, increased nitric oxide in the endothelial cells, vasodilatation, for example, release of prostaglandins, et cetera, et cetera, et cetera, et cetera. Clinical findings in sepsis. Early on, patients look bad. I mean, they look sick, et cetera, et cetera. And I had to learn this the hard way on the wards. Just hyperventilation, altered mental status. Complications, a lot of bad things happen. So full-blown sepsis is sort of you sort of kind of get so you recognize it. This person is bad, sick. Kidneys shut down, tubular necrosis, liver, heart failure, GI. And notice, as in the patient that I started off this hour with, that nausea, vomiting, and diarrhea can be the initial manifestation in systemic lactic acidosis. So all of this stuff, again, to kind of get back to the poem that we quoted yesterday, just knowing these little facts and asking questions, being skeptical, very important. Now, here we start to get into some of the questions for the exam. Petechiae early in the course suggests especially meningococcemia, Rocky Mountain spotted fever. There's a skin lesion that we're going to talk about. Mark this well, ecthyma gangrenosum, characteristic of Pseudomonas sepsis. Toxic shock syndrome, if somebody gets red. About 3 or 4 years ago, when I was, I guess it was earlier, it came out in 2002, when I was doing a textbook of infectious diseases in primary care, I sent a survey to 600 infectious disease specialists around the country looking for mistakes. I'll talk about this tomorrow a little bit, that they've seen made in primary care. And one of them was, it led to death or disability. And one person wrote in, this staphylococcal toxic shock, and some doctor, I guess, in student health clinic said, this co-ed can't be very sick. She's been out getting sunburned. That's staphylococcal toxic shock. People without spleens, pneumococcal sepsis, very important. There are other critters that can also do that. And it's in your handout. I'm not going to examine you on it. You were, if you had no spleen and were camping in Rhode Island, it might be Babesia macroti, which looks like a little bit like malaria on a peripheral blood smear. If you were a mail carrier and got bitten by a dog and had no spleen, it might be Capnocytophaga canamorsus, dog bites. And the other encapsulated bacteria can do that. We'll talk about that a little bit. We're going to show the lesions of the meningococcus tomorrow. Rocky Mountain spotted fever we're also going to show. Staph aureus, purulent purpura, Pseudomonas, again, mark this well, ecthyma gangrenosum. We showed yesterday the rose spots of typhoid, endocarditis, bacterial endocarditis, which we're going to talk about in this lecture. And you should be able to roll out and just roll off the tip of your tongue when you present a patient. There were no ulcer nodes, splinter hemorrhages, Janeway lesions, or petechiae. That is medical speakese for I considered endocarditis. Anthrax we're going to talk about tomorrow, the lesions of that, et cetera, et cetera. These are some in meningococcemia, early lesions, fluent purpura. Mortality here is very high. Meningococcemia, red spots on the skin rashes get of this sort a lot of importance. Ecthyma gangrenosum, Pseudomonas sepsis, particularly in oncology patients. It evolves into this black eschar. What's basically going on there in pathological terms? Why would the skin be black like that? Necrosis, what would be another term? Excuse me? What did you say? Death? Good. What's another term? Excuse me? Infarction, right. Basically an infarction of skin due to deprivation of its vascular supply. And it turns out that Pseudomonas is an opportunistic organism, but once it gets a foothold, it has an ability to invade the walls of blood vessels. It's angioinvasive. So what you're having here, as I look at it, is an infarction of the skin. We talked about disseminated gonococcal infection yesterday. Here's some more examples of that. This was a patient I saw in practice some years ago, a former Miss Lexington County. Notice the excellent manicure and the diagnostic lesion of the gonococcal arthritis dermatitis syndrome. Staphylococcal bacteremia, we're going to talk about a little bit. We talked about staph, and staph are increasingly very, very important. I'm going to skip over this slide and that one, and this from a wonderful review article recently. And I'm going to offer the pointer to my budding genius over here and have him explain ICAM and all this good stuff. Obviously, the point is all these wonderful things of the Staphylococcus going in here, causing abscesses to form, et cetera, et cetera, et cetera. Wonderful chance to correlate what's going on with the patient being very, very sick. And more, new drugs are being developed with the attempt to form monoclonal antibodies, for example, against a lot of these things, tumor necrosis factor and other stuff, and that's going to be an emerging story. We're going to talk about some syndromes, staphylococcal toxic shock syndrome, high fever, rash that desquamates, and these toxins that cause active superantigens causing massive cytokine release, staph toxic shock. And you've had this to some extent, is that correct? What? So I'm going to, no questions from me about this year, and I wrote these questions last night. But this is a rash from toxic shock, looks like a sunburn. And unfortunately, this fairly diagnostic finding of the skin peeling off comes late. So that's, what it was. And oftentimes in staph toxic shock, which can result from a wound, the source is not apparent. In contrast, in streptococcal toxic shock, usually there will be some evident source. Streptococcus can also express superantigens release, resulting in massive cytokine release. About half of the patients will have necrotizing fasciitis. Yeah, notice the nonspecificity of these early symptoms. Chills, fever, nausea, vomiting, diarrhea, which might direct your attention at the gut. And this was a patient with streptococcal cellulitis, for example, and note the primary streptococcal infection there. Sepsis in the asplenic person, mark this well, frequently fulminant with massive bacteremia, pneumococcus, up to 90% of the infections and 60% of the deaths, and we mentioned these other organisms. Why would that be, sepsis in a splenic person causing death? Often within the first year of splenectomy. The way I look at it is the spleen is sort of a strategic place for the early response to infection in the absence of specific antibody. One, for mechanically trapping bacteria, and two, for generating the early immune response. I give you a 24-year-old white male with headache, nausea, and vomiting, been in excellent health, smoked marijuana a little bit, sent home with symptomatic treatment, came in the next morning moribund. I had known this little boy, grew up across the street from me. What's wrong with that picture? Excuse me? What?
Well, he had his spleen removed, right?
What?
He had his spleen removed?
No, he hadn't had his spleen out. He had meningococcal disease, headache, nausea, and vomiting, and that can be looked at. He was treated for gastroenteritis. What are the signs of increased intracranial pressure? We'll talk about this tomorrow. Meningococcal disease, little red spots, and we're going to talk about that tomorrow. I'm going to tell you about my buddy check. This was a person who was a student at the University of South Carolina sitting on a stretcher in the emergency room at Richland with these little red spots. And this is one of the few things, overwhelming meningococcal infection, that can kill one of you within an hour or two. One of the few infectious diseases that can do that. This is why meningococcal vaccine is being prioritized for freshman college students. These are other lesions of meningococcal septicemia. Meningococcal disease in this country is uncommon, so people are going to overlook it. It's uncommon. And this is by way of review. A question that's apt to show up on exams, it's not going to be on my exam this year, but to know about, is that people with late-acting complement deficiencies tend to have recurrent neisterial disease, meningococcal or gonococcal. And this is because that's important for the serum bactericidal system, which, as you recall, is a system of in which complement plus antibody, type-specific antibody by the classical complement pathway, non-specific antibody by the alternative complement pathway, actually punches a hole in certain organisms. Any questions there? This is a 64-year-old man coming in with fever, hypertension, cellulitis, bullous skin lesions. Got back from New Orleans. He had a history of cirrhosis where he ate raw oysters. What's he got? Excuse me? He got what? Vibrio vulnificus. So remember, if you have cirrhosis of the liver, you should not eat raw oysters, right? Should not eat raw oysters. I went to the Oyster Club last night. It was written up in the newspaper a few years ago, and I got quoted in the newspaper saying that. I hope it helps somebody out. Vibrio vulnificus, by way of review. Cirrhosis, chills, fever, wound infection. Any questions there? We're going over some key syndromes very rapidly. 41-year-old man with the worst headache he ever had, myalgias, rash, returned from camping in the Smoky Mountains a week before admission. What's he got? Rocky Mountain spotted fever. What rash did we talk about yesterday that involves the palms of the hands? What? Secondary syphilis, right? That would be a macular rash. This is a particular rash. Unfortunately, at 7 days, only 43% of people, according to one study, had a rash, even at 7 days. So this may not help you out early on. So that will burn you. There are 5 infectious causes I know of the worst headache ever, and they are Rocky Mountain spotted fever, meningitis, brain abscess, sphenoid sinusitis, and falciparum malaria. Now, for the remaining 7 minutes, we're going to do only very partial justice to one of most internists' favorite diseases, starting with this case history of a 65-year-old woman with diabetes who during a flu epidemic has fever, chills, and aching all over, comes in, got bibasilar rales, no heart murmur. She's admitted for treatment of her heart failure, and she dies with endocarditis. We're going to talk about infective endocarditis here. These are terms for endocarditis. We're going to talk about this one. Terms acute and subacute are seldom used nowadays. Non-bacterial thrombotic endocarditis simply makes the point that you can have clots on the heart valves that are not infected. And in endocarditis, septic vegetations of endocardium usually involve the heart valves. Acute endocarditis, normal heart valves, highly virulent organisms. Staph aureus is a prototype. Subacute endocarditis, less virulent bacteria. Mark this well, Viridans streptococci are the prototype and the most common cause across the board still of endocarditis. Classically, in endocarditis, the main features are a predisposing valvular lesion, multiple positive blood cultures, embolic phenomena, and then some evidence of an active endocardial process. And I'm going to skip this for time. In the pathogenesis of endocarditis, what is thought to happen is that one has particularly the subacute model, a lesion that predisposes, and as I'll show in another slide, this is particularly things like aortic regurgitation and mitral regurgitation going that way, or ventricular septal defect with blood going that way from the left ventricle to the right ventricle. And what happens is you get a little thrombus that'll form right there. And these kind of thrombi form on an ongoing basis, which is one reason the valves eventually become deformed and scarred. And if you happen to get bacteria in your blood, classically from pulling a tooth or something, but say you brush your teeth vigorously, whatever, get a Viridans strep in your blood, the bacteria will settle out in that vegetation, and then they'll proliferate unchecked because white blood cells can't get in there. And then these vegetations can, of course, break off and go elsewhere and set up shop elsewhere. This idea was developed as follows, that if you take an abnormal blood going from a high-pressure chamber to a low-pressure chamber, as in aortic regurgitation and diastole, blood goes from the high-pressure aorta to the low-pressure left ventricle. In mitral regurgitation and systole, blood goes from the high-pressure left ventricle now to the low-pressure left atrium, and also from the high-pressure left ventricle to the low-pressure right ventricle. And so every time the vegetations will form here, and you can do the same thing by, say, taking a test tube and putting agar in it and then squirting a column of fluid down with bacteria in it, and the bacteria will form colonies right after that constriction. And this shows you what I've just put on the board there as to why the vegetations form on the ventricular aspect of the aortic valve and the aortic regurgitation, atrial surface of the mitral valve. You can also get a jet lesion, et cetera, et cetera. So this is just a sterile clot from non-bacterial thrombotic endocarditis. This is a removed valve in somebody with bacterial endocarditis. There's the valve there. This is this clot. Notice these clumps of bacteria staining with the hematoxylin on an H&E section. And the point, of course, is that all of the white cells in the body are flying over this as they go through the bloodstream and go through the heart, but do not have any access. So this is why endocarditis untreated was uniformly fatal in the pre-antibiotic era. I only got 2 minutes left to finish my endocarditis lecture here. So I'm going to suggest to you that you read what's in the boldface print. Suffice it to say that this really is one of the great diseases because you just have to think about it to make the diagnosis. You have to think about it. And this is, you have to suspect it because one of the things that can happen, particularly in primary care, is that the patients come in with nonspecific symptoms and you give them antibiotics and you suppress it but you don't cure it. And you may make the bacteria more resistant. Blood culture is important. Now echocardiogram shows the vegetations. I want you to be able to rattle this off on the tip of your tongue. There were no splinter hemorrhages, ulcer nose, Janeway lesions, or petechiae, or Roth spots. And some skin lesions. I'm going to show you some pictures that I took over the years from patients I saw here in Columbia. This is staph endocarditis with this pustule on the skin. See things on the skin, think endocarditis. This guy has got a pustule on his nose. These are Janeway lesions, spots on the hand. Here's the same patient. This was a lady I showed you earlier with a big splinter hemorrhage in the nail bed, called a splinter hemorrhage. This is her heart, showing the vegetation of the aortic valve. This guy had a few petechiae on the heels. He had pseudomonas. Petechiae, little red spots. This is a ruptured papillary muscle. And I'm going to leave you with this, that Viridans strep are the most common cause of endocarditis. Staph cause about 20 to 30%. All sorts of bacteria occasionally cause it. And one final point is that the staphylococcal endocarditis, two basic syndromes of it, one on the right side of the heart and the other on the left side of the heart. Endocarditis on the right side of the heart, the tricuspid or pulmonic valve, staph, people who shoot up IV drugs. And in that case, the emboli that break off would not go to the brain and cause a stroke, or to the spleen and cause left upper quadrant pain, or the kidneys and cause flank pain and hematuria, but they would go where if it was on the right side of the heart? Lungs. So you often see patchy bilateral pulmonary infiltrates. So I'll stop there. Thank you, endocarditis.